No, thank you very much. This is Kaori Kaorabayashi. I manage the UNAIDS technical support mechanism. And just to say thank you so much for our partners, Global Fund, FHI 360, Bill and Melinda Gates Foundation for funding this. It's a very important topic that a lot of us have been talking about on virtual demand creation and health service delivery. Virtual interventions, a lot of it has been in the funding request for GC7, and this is one of our initiatives for capacity building for our TSM consultants. And of course, we invited other partners as well and our UNAIDS country offices. But I think this is one way that we can help provide capacity building support to our consultants with the view that our consultants will be able to provide the support to our countries. So thank you very much. And over to you. Thank you.
Thank you. And Kaori, if you have any other colleagues that are joining, please let me know if I should promote them to be a panelist. Today, I am in South Africa, and so I'm a little closer to Asia to be able to host this call at this time. All my other colleagues are sleeping, and so it's only me managing this this webinar from the hosting side. So it might be challenging for me to find all the questions and to track any engagements outside of my shared screen, but I will try. I can see the chat and I can see the participants, so we'll give this a try. And also, I am in South Africa, so we have load shedding, which is when the electricity is cut off. Everything should be fine for me to host, but there's a chance that I might get disconnected. And so, Kaori, if that happens, you might be able to alert the attendees and let them know, and we'll have to share maybe a video recording of this afterwards. So I don't think that will happen. I think we'll be fine, but let's go ahead and get started. We have a pretty packed agenda. It is a 90-minute session today. And thank you for giving those introductory remarks. If there's something else you'd like to clarify or add later, feel free to jump in. My name is Ben Aveslage. I'm Associate Director Technical for Telehealth at FHI 360. And my team, including Shanti and Danny, are working on this contract funded by the Bill and Melinda Gates Foundation to support the Global Fund to accelerate the implementation of virtual HIV interventions and virtual interventions for health more generally. And this webinar is part of that. This webinar is a 4-part series, mainly the same content, but just for specific regions. We had one just yesterday or the day before in French for Africa, and we have one later today for Europe time zones. And then that will conclude the webinar series. I'll go ahead and get started. We already reviewed the housekeeping. You can feel free to rename yourself as a participant to match your name. You can introduce yourself in the chat. Attendees' microphones will always be muted, but you can raise your hand. I think I will easily be able to find you if you raise your hand, and I can allow you to speak. And you can do that at any time, or you can write in the chat with any questions at any time. And we will have a dedicated Q&A session to review those together. So the objectives of our work under these engagements are to help scale implementation of virtual demand creation and health service delivery approaches. And we've seen that many PRs under the Global Fund have submitted funding requests that have included virtual interventions, which is a great progress. The specific objective of this webinar, which sits within that overarching general objective, is to develop the capacity of the TSM consultants on virtual demand creation and health service delivery approaches. Demand creation is a process, capacity building is a process. So this really is step one. So we're gonna do a light orientation to many relevant approaches that could be leveraged by Global Fund programs. And we will provide links to available guidance and resources. This isn't necessarily a full-on training. Your capacity may not be fully developed, but what you would have is you would have more familiarity of what are the approaches, where are they useful, and where are some resources that you can learn more and guide yourself through potential future technical assistance or implementation. In the same contract that we are providing support on these webinars, we have done some other work too to support accelerating virtual interventions for health. One is a budgeting and programming aid or guide for virtual HIV interventions. That was published in 2022, and you have a link here. We'll share the slides. We did a similar webinar for demand creation only for the LAC region in Spanish and translated to English, and you can watch the webinar here. It was done around May of last year. And we did a country readiness assessment, which looks at all Global Fund countries and provided some metrics to be able to prioritize where are virtual interventions most optimal mostly for the HIV program. What we looked at were mobile phone usage, internet usage, and social media usage in each country. We then looked at some other factors like existing virtual interventions that are known about, other platforms that could be scaled or leveraged. And we looked at the Global Fund funding requests, and we noted where countries had plans for virtual interventions. And from that review, many, if not almost all, of the Global Fund programs in Asia were prioritized. And so I think that's why we have a pretty good showing today from consultants and other folks in Asia. Mobile penetration is high across most countries in Asia. Social media use is pretty high. Lots of programs are very skilled already in virtual interventions and have been using them for maybe the last 10 years. Others are still getting started, or maybe some particular programs are interested to scale their approaches. And we also saw many Global Fund funding requests from PRs throughout Asia with pretty sophisticated and detailed plans for the use of virtual platforms in their program. So this is one of the more scary webinars because I think I'm preaching to the choir, as we say in the US, meaning that a lot of the folks involved in Asia already know about these approaches really well. So I'll try to be a little bit more humble today. And I also believe that a lot of the folks on this call might have a lot to contribute in this area of virtual interventions. So feel free during the discussion to raise your hand. I can unmute you and you can share some examples, or you can share some questions as well. And we'll do our best. I'll do my best to address those. All right. And as a framing remark to wrap up these other activities that we're supporting, after this webinar series, you can reach out to us if you are called upon to provide support to a particular Global Fund project through the TSM, or if you want to learn more about any of these approaches, you can reach out to us and we can have meetings with you to follow up on any questions you have about these approaches. We do have time to be able to support you in that way. So, take a note of our contact information, which are on all of these slides. You can contact us individually or specifically for your own needs to prepare you for any TA you might be doing in the field related to virtual interventions. So here's our agenda. We only have 5 more minutes of our first section of the opening and the technical review. We then have the first main section of content on virtual demand creation, 10-minute Q&A, and then we have the second session on virtual health service delivery, and then a 10-minute Q&A. And then we have a little bit of time for closing remarks, and I want to guide you about how you can access some available resources. And I see a question in the chat. The slides will be shared. Yes. I see another question. Would there be an opportunity in the future for a full training on this subject? Under our current contract, FHI doesn't have the time to develop a full training, but we can do, for an individual consultant who's interested or has been requested to provide TA to a country on any of these approaches, you can set up a call with us, and we can work through the request of the country with you and prepare you with the right resources and provide some advice. I think that's the level that we are prepared to support. And I think a full training isn't in the plans right now immediately. However, we'll be in touch with our focal points at the TSM, UNAIDS Global Fund, if there are opportunities to open up a fuller training course. There might be opportunities that are managed within UNAIDS itself, as opposed to delivered by my team. But those are some options. So I have an introductory poll. Let me see if I can figure out how to do this on my own. Polls and quizzes. Okay, let's try this. So I'm going to launch a 3-question poll. Let's go ahead and get started. So there's 3 questions here. Take your time to review each one. The first one is just assessing your knowledge on what is telehealth. It's one of the key terms and topics in this webinar. I think you're able to see the poll and the question options. Can someone write in the chat if it's true you can see the poll? I see some people answering the questions now. I think you can. That's great. So go ahead and please, you see the poll. First question, how would you define telehealth? I provided 3 options that I found on the internet, and actually only one option is a definition for telehealth. The other 2 options are definitions for other things related to telehealth. So it's kind of like a quiz. So go ahead and give the options that you like. We'll reveal the responses. The second question is gauging your own confidence and your own ability to provide quality technical assistance to Global Fund programs on telehealth and related approaches. So you can go ahead and rate yourself from 10, very confident that you can provide high quality TA on telehealth, to 0, really not confident at all. And any response is fine, because today is just a learning session. And you're not obligated to know anything in particular to attend this session, and that's totally fine. And the last question, what are you most interested to learn about during this webinar? You can just write a few examples. It's a very short, limited response. If there's particular kinds of approaches or considerations or concerns about telehealth that you want to learn more about, write a few examples there. So I see we have around 50 attendees, and we're getting some responses. We have 26%, sorry, 26 attendees answering the first question, the second question, 30, and the last question we have 15. It's a good start. I'll give it another few moments before we close the poll and kind of like review the results together. I really hope that I'm managing this well, and I'll be able to show you the results. All right, let's go ahead and in the poll, I hope I'll be able to show you the results. Share results, there we go. All right, so I hope you're able to see the results of the poll. If someone can give me a thumbs up or a message in the chat that yes, you can see the results, that would be great. Great. How do you define telehealth? The first option, 18% said the remote diagnosis and treatment of patients by means of telecommunication technology. So that's actually the definition of telemedicine. So telehealth is a broad area. Telehealth can include any kind of health communications, even demand creation. It doesn't need to be by a health professional or clinician. But telemedicine is a smaller section of telehealth. And that's usually only provided by medical professionals. It wouldn't usually include community health staff or virtual demand creation approaches. So this telemedicine definition is the remote diagnosis and treatment of patients, which is very particular and actually not really a focus of my team's work. Most of my team is community services, virtual engagement of clients and health services, service navigation, not as much on the remote diagnoses and treatment. The only exception would be mental health, because you can do mental health treatment remotely by a virtual consult very easily in many places. The second option, the provision of healthcare remotely by means of telecommunications technology. So that is a definition of telehealth. Most people selected this one. And from our team side, we understand this pretty broadly to mean many areas of healthcare. It can include online marketing of health services online client outreach for health services, all the way through online appointment booking, virtual case management, virtual consultations with your doctor. So it's a pretty broad area. But for us, we really focus on, and for what's the content in this presentation, it's really focusing on virtual reach and engagement of clients in health services. It's not like virtual training of doctors, because that doesn't engage beneficiaries or clients. We're really focusing on engaging clients. And the last one, the remote video audio consultations that takes place between a patient and a clinician. This is an example of telehealth. It's also an example of telemedicine. This is the definition of a virtual consult. So all these options are relevant to telehealth. The true definition is option number 2. Great. Second, what is your confidence and most, confidence in providing TA related to virtual interventions or telehealth? And most individuals are falling in the middle, which means you're mixed. You're not super confident. You're not very unconfident in your abilities to provide TA. If you're a skilled TA provider, a lot of times you can jump into a new topic with existing examples from other countries and provide still a very strong value to the program. I hope that by the end of today's session, you will know how to access some of those examples and tools, or access help if you need some additional support and guidance. And the last question I would like to view. All right. I'm not sure if you guys can see. I'm going to try to see. There's an open response to the last question. What are you most interested to learn about? I'm just going to review some of them. Okay, someone's interested in patient satisfaction, strategies and approaches on virtual demand creation, service provision. I love the telehealth, decrease waiting time, transport cost, effective time usage, guidelines on quality telehealth provision. Yeah, so you may not be able to see my screen. Right now, I'm viewing the results of the final question. What are you most interested to learn about during this webinar? And I had to open up a different screen to view these responses. So I'm listing some of those that I'm seeing that look interesting. Someone's interested in challenges in lower or middle income countries related to telehealth, how to undo them, how to do outreach to key populations online, enablers and barriers in delivering telehealth. Okay, just going to confirm we have all these. Diagnoses and treatment through telehealth is not a topic that I think we're going to focus on too much here, but by the end you'll see if we've addressed it for you. Yeah, how to evaluate online demand creation activities. That's a great one. Okay, great. Okay, great. So most of the interests are very aligned with the webinar. There are some that may not be specifically focused on, but we do have resources for. One is patient satisfaction with services, which you can assess through virtual platforms like an online survey, and that's actually, I think that's not included here, but it is a topic that we can share on. And then remote diagnosis and treatment provision isn't what we focus on here, unless it's like a virtual consult, like for mental health. That is covered here. All right, I'll go back to the PowerPoint, and I just want to confirm in the chat that you can see the PowerPoint. I've been moving my slides around a little bit. Yes. Okay, great. Let me go ahead and I'm going to stop sharing my video, but I'll keep the slides and we're going to go over the technical overview. And I'll make this very quick. Why do programs go online? To expand reach to new audiences who are online, to improve efficiency through enhanced targeting available through online platforms, but also self-care, meaning clients can do things on their own. Also, going online can help meet client preferences because a lot of clients who you reach online kind of want to stay online to engage in health information and services. It's more convenient. It can be experienced as more discreet or private. And then lastly here, it helps. Oh, I see that someone says, you can't hear me. Quick question. Am I still audible for other people? Yes. Okay. So great. Thank you. Someone, if you cannot hear me, it might be your own audio settings. However, if you would like to speak, you can go ahead and raise your hand and I can unmute you because by default, everyone is muted. So the last reason why programs go online might be to develop their health system resilience, to be able to be more responsive in emergency or pandemic situations like COVID-19. With COVID-19, a great expansion in telehealth to allow health services to reach people remotely in case of physical distancing or lockdowns, etc. I want to highlight a couple important trends. Mobile connectivity is quite high globally and increasing each year, especially in Asia. It's already very high in Asia, in many countries in Asia. It looks like I went to the end of my slide deck. Apologies. All right. So you can see here internet usage as a percent of total population in different regions. And you can see Asia being quite high as a percent compared to some other regions. And I want to also note another relevant trend is there's an alarming increase in security concerns for some key populations or LGBTQ plus populations in some countries. This is a New York Times article of new, more restrictive laws in Uganda related to LGBTQ audiences that are limiting their access to health services. And these are really, really important to be tracking and understanding how the social context and the legal context might impact how you do online demand creation or virtual service delivery. Very, very important. Also, because so many people are now using virtual platforms, many countries are introducing stricter data privacy laws, and some countries also have limitations on certain social media applications or other apps that can be used in the country. There's some, crackdown or limitations placed on some social media platforms by governments. And the stricter data privacy laws are usually ones that are done or drafted to protect clients and beneficiaries, but those protections need to be acknowledged and understood by programs that might be using virtual platforms to collect any information about clients, because you have to abide by the provisions of data privacy and security. So that's another important one to track. And you can see here that there are many countries now introducing data privacy and protection legislation. You see those in the blue or the greenish blue, the darker color, where they have the legislation. Those in lighter blue are drafting it. And just a few countries don't really have much legislation on data privacy. So I would say most countries, this is definitely something to check in on and make sure that you're in compliance with. Here are, I'm going to start by presenting a global framework for telehealth across the client care continuum. And you'll notice that this framework starts with planning your virtual approach, reaching your clients online, referring them to health services, delivering those services to clients, including through virtual platforms, re-engaging clients over time in health services. And then the last stage is kind of using data from each of the prior steps to improve your health services. So you can see the client care continuum above, which is very similar to the HIV services cascade, but we just made it a little bit more generic so that it can work across some other health areas. And below, you're beginning to see the outline of some virtual approaches that could be used to support each of those stages. And now I'm populating some of the more specific approaches, which a lot of these I'll be reviewing in the next slides. And then here again are some sub approaches. One of the key ones I'll highlight is under the green refer section, an area called self-care. You have in dark green an application called Aura/QuickRes. This really just means like a client-facing online health navigation tool. On my team side, we created such a tool and it's called Aura. It's also called QuickRes. And it has all those functions you see around it. So in lighter green. So we're going to review that a little bit later. This framework is meant to be to help inspire you and you be able to see the relevant approaches across the continuum, and you can kind of see how they all fit together. So we're going to get started with virtual demand creation. This is going to be an orientation on approaches to plan and to implement virtual demand creation of health services, which would include like marketing, online outreach, etc. So the first subsection is planning approaches. So approaches to help plan your demand creation. Some of these approaches aren't just to plan demand creation, it's to plan your entire virtual or telehealth approach. It could, include many other phases of the client journey. So some of the approaches are doing reports or situational analyses of the existing approaches, doing some data collection of the target audience that is online to better understand their preferences, etc., like online surveys, doing some mapping of the places online where you could find or reach these audiences, and that's called social media mapping. There are additional audience learning activities. And then once you have this data collected from these prior options, you then can consider drafting a roadmap or an implementation strategy that leverages the data you've collected from the prior steps to putting forward a strategy for actual implementation. Here's what we want to do. We're basing it on X, Y, and Z data. And for the consultants, I actually think that this section is probably one of the most useful for you because many programs, maybe not in Asia, but maybe some programs in Asia would be very interested to get started on virtual approaches, maybe for a new audience that they haven't leveraged or haven't engaged online before. And as a consultant, doing these initial planning approaches or audience learning activities or assessing the landscape of existing digital interventions in a country and making recommendations or developing a strategy, I think all those are things are very well suited to like a broadly skilled consultant. As you get further into the strategies, more advanced or strategies that directly engage clients and health services, It's a little more advanced, but I think these are always a great starting point. We have an example of these virtual intervention situational analyses. We've done them multi-country. You can see the digital health landscaping report for Africa on the right-hand side, and we've done it for particular countries. We've done it for the Philippines, or with the Philippines. We've also done it for the Gambia, which you can access or you can request, and we can send it to you. And we've done it as a 4-country assessment of virtual approaches for condom demand generation in Africa. So we've done this multiple times, and honestly, just by reviewing the visas themselves, the document, you'll get a good sense of how to do it yourselves. Really, it just involves desk review, web and social media searches to see what is happening in the country related to virtual, and then you use that to identify maybe some gaps and areas for optimization. And then you have some stakeholder interviews and validation meetings, maybe with the KP Technical Working Group, maybe PEPFAR partners, maybe the Global Fund team and their in-country partners, to ensure that what you found online is accurate and more or less comprehensive of the virtual approaches that are used and their current status. Social media mapping, I mentioned, it's a workshop format where you bring in community members to map or find and map Facebook groups or pages, social media influencers, or potentially group chats where members of the target audience might be reached. This is a potentially more sensitive activity. In some countries, you might opt not to do it because creating lists of Facebook groups and pages where you can find MSM might be too vulnerable. In other places, it might be very helpful and not too unsafe. So you can see here a link to the actual technical guidance on this approach and the sample tool of how to collect it. Usually the results are stored in a password-protected Excel file, and an HIV program will manage sharing with anyone involved in outreach or marketing or linking up with influencers. They'll manage sharing with those individuals the recommended pages or recommended influencers or group chats to do outreach with. That's generally how it's used. You can see here on the right in the Philippines, we did some mapping. And this just shows you summary, for all of the mapped groups, pages, influencers, or chats, like what number of them we were able to find where we could find MSM, and then the breakdown by type. You have 85 influencers that are relevant to reach MSM, 85 groups and pages, 22 group chats. This is not exhaustive. It's supposed to be just a start to find relevant places to find the audience online. There's no way to do this exhaustively. It could take forever. So really, you just take a certain amount of time, collect what you can, use that as part of your outreach, and then you can kind of snowball from there during actual implementation. Quick online surveys. This is an approach where you have like a short-ish survey, definitely not a IBBS type survey. The point is for a program who wants to reach a new or slightly unique audience online who they don't really know that much about. So these questions ask about their HIV risk profile, but primarily their preferences for how they would want to engage in HIV services. Preferences like, how would you prefer to learn about HIV? And options like search for it on Google, or ask a friend on social media, or ask my followers on TikTok, or meet up with a peer educator, or go to a health facility, or call a doctor. Like, we want to know how clients want to engage in health services so that the program can actually align itself to offer that information and services in the ways that clients are already looking for it. So it's a really nice activity, actually, and it can be done pretty low effort. It's not typically understood as a research activity. You typically don't need to do IRB approval, things of that nature. You can see some example guidance here. We have the tool itself that we've used that you can modify and use on your own. And we have some examples of the results from various countries here as well. Feel free to review those. And here are some slides just showing the kinds of questions the survey asks. And you'll be able to understand how these can be used for your planning of your health service delivery approaches and how it can inform your marketing as well. It's like an entry point. It's like the first step into understanding your audience, which you would probably need to follow up with maybe focus groups to learn more. You see here, like, how do you normally prefer to communicate using your phone? This is going to help the program understand, okay, among this new target audience, they're going to want to be messaging more, or maybe in one country they want to just have a phone call quickly. This is just to get a sense of the method of virtual communication that's going to be the most relevant for them. What topics, issues, or interests do you engage with in social media? So this is going to allow you to know, you're going to filter your results by clients who identify with your target audience, and you're going to look here and see what are their interests. You can use this to be able to target your ads towards your audience who are interested in these topics, or you can bring in these topics into your creative designs or into your marketing. So you can associate your HIV services with food or with mental health or with human rights. All these are things that are shown as interesting to this target audience, or dating. This just gives you some of those entry points of how to align your HIV brand and communications. Here are some other options. I will send the slides. You see, you can kind of review these examples. I'm definitely going over time, so I'll try to go a little bit faster. Got some other planning approaches. This was an interesting one we did a while back in India. You can see in Mumbai, we mapped the density of Grindr users across the city and across various days in the week. And you can see weekend hours, super dense Grindr users in the north, and then weekdays during the, when people are working, not towards the south. It was used to help direct ads on Grindr, and it did not collect any individual client information. It wasn't individual Grindr user locations. It was just selecting a point and then counting the number of profiles around it, capturing the number of profiles, not an individual's location. But here are some other examples, and we have the details of those approaches from past AIDS conferences shown here. And we also have examples of roadmaps or implementation strategies that can be developed based on all those prior approaches that were mentioned. So you can go ahead and review these examples. You can also, again, a lot of the documents here are available upon request, and that's because we submitted these deliverables to the stakeholders, but they were not meant to be published online. However, they're not private information. We can still share it with you. We just did not format it to be published online. So you can go ahead at any point and ask by email if you want a particular document, and we'll go ahead and send that to you. And we might note that it's a draft, or that you shouldn't circulate it widely or something like that. All right, the second subsection is on actual reach approaches, so virtual demand creation approaches, social media, and these approaches are segmented by who are the staff implementing them. So social media officers, social media influencers, online outreach workers, and community mobilizers. I'll explain what each of these are and give some examples. So we can see here, I'm going to be using the same little diagram here to explain these different approaches. And what you see here are a bunch of emojis. And what these emojis mean are people of different demographics. It's basically the online audience. So what we're demonstrating here is how each of these online demand creation approaches reach and engage clients and health services in slightly different ways. So the first one, social media officers, they have two strategies they can use to create demand. One is organic, and one is inorganic. Inorganic means a paid promotion. So organic reach involves managing and growing a following on social media among the target audience through posting interesting and engaging content. You see here a little Facebook icon with a little ring around it. So that's a Facebook page, and the ring are their followers or members. And through an organic approach, the page will continually reach out and engage more people, and the growth and the number of followers of the page will increase gradually. And that's why it's called organic. So inorganic reach involves implementing paid advertising campaigns on social media, dating apps, or search engines to reach all target members meeting the defined characteristics. So you see here among all the emojis, when we did the inorganic, essentially you're leveraging a social media platform's data capabilities to send an ad to all the users who meet a predefined characteristic. And so here it looks like it's targeting pregnant women. You see some pregnant women emojis and some other women. So it's just it's already you define your audience, and it sends a message to all of them. And this kind of approach is great to broaden outreach to new audiences that are very different than the people that you would be reaching that are already connected to your page or your organization. Social media influencer promotions start by identifying individuals on social media who are popular and influential among the target audience and engaging them to post to their followers about the program. People reached can be linked directly to HIV services, or they can be linked back to the program's social media channels, to increase the followers, or they can be linked from a social media influencer to an outreach worker who can really help the client get in for services. And you can see here that 3 individuals, are highlighted as an influencer. They are part of the target online audience. They're part of the community. They're not part of the HIV program necessarily, not necessarily staff. And when you engage influencers, depending on their size, a medium or macro influencer, their reach is likely to overlap. And that's why you see these bigger circles that are overlapping. And that's totally fine. It means you have multiple trustworthy voices, all reinforcing a similar demand creation or behavior change objective. And that's great. So online outreach workers hired by the HIV program individually, they individually support clients, reach through other demand creation approaches to access services. They also reach directly into online social networks through peer referrals, known as and known social media groups and pages where the audience may be reached. So they use a couple approaches. The online outreach workers can be on call to receive referrals from the social media officer who's managing the Facebook page or the ads. They can also receive referrals from the social media influencers. And then the outreach workers can also do their own active outreach and go on potentially dating apps, but certainly social media and engage people, their friends, and ask their own friends and people that they are clients they've already engaged to refer other clients to them and help those new clients get in for services. And so that's why you can see the outreach workers reaching out into the online audience through individual people and making referrals from there. So community mobilizers is a very interesting approach. This is when members of the community who are actually in the online audience and who are not staff, they have access to hard to reach segments of the target audience online, and they can mobilize their contacts to access HIV services directly. The program may provide incentives to these mobilizers based on volume of clients they individually mobilized. So this is sort of taking the work of an outreach worker and outsourcing it to individuals in the community, not staff. So it's an interesting approach. I think more of that has been done under PEPFAR funding than Global Fund, and there's a lot of guidance available on that approach. And we have some examples of how to do it online as well. I'm going to go through some examples of of the demand creation approaches. iFlex in Jamaica, they really institutionalized online demand creation. It's really their main approach, as opposed to in-person mobilization. They have online outreach workers. They have a social media presence and Facebook and Instagram page with content that's, targeting their audience of younger MSM. And they have hired in their team content creators, MSM community members who are well-versed in how to communicate online. So it's really been sort of institutionalized, and they're not afraid to, take their funding and invest it in their team to be able to have the human resources and skills to deliver on this. So this is a really great example of an organization that was able to introduce and sustain online outreach. They use online outreach workers, but they also do social media officers, managing a social media page, etc. Here are some of their content. Definitely looking a little bit more masculine, but a lot of their copy, and copy meaning like text use, are pretty innovative. During COVID, it says going out, wear a mask, going in, wear a condom. So they're using the local lingo and such. And you can tell that they're benefited by having people that are skilled in content creation, not just, a normal program officer who doesn't have a background or skill set in graphic design. They really, brought on someone who does, and that's great. They also have very interesting and engaging ways to engage their target audience. It's not just content. They do live polls, live stories, engaging people in more interesting ways. It's not just content. It's not just like static content that's put out there. So considering some of those might be more interesting for some audiences. Here is an influencer campaign in Indonesia. This is Stasia, an influencer, transgender makeup artist in Indonesia. I think we have a couple of people attending from Indonesia. She, at the time, this was like 2018, had 166,000 followers. A creative agency was hired to help her record these videos. And what she's doing is just demystifying the experience of entering a HIV clinic for testing. And she linked, with this video, she linked her followers to a website where they could just book appointments to go to a clinic just like this. In Guyana, we have some examples here of social influencer posting on TikTok about how easy it is to book an appointment. You have in the middle posts on social media that explain how easy it is to book health services online. And you have outreach workers who actually physically meet with clients to help them book appointments or access services. I apologize. A lot of the examples here are from Africa, because we just had this webinar in Africa, or for the countries in Africa. I also want to recognize that there are many amazing and highly advanced approaches in Asia. And so we don't have a lot of those highlighted here. And feel free to raise your hand and give examples if you'd like. I'll pause in just a minute. So here are some examples from a condom demand creation campaign that we supported in Africa. And let me just pause here. I'm a little bit over on time, but we do have some time for any Q&A. Feel free to write your questions in the chat. Also, you can raise your hand. I should be able to see it. Or you can put in the chat that you'd like to be unmuted if you have a question. So we can take questions on the planning approaches, on the reach approaches, or anything in general. I see some questions in the Q&A box. All right, let me read one question. Thanks for the great presentation. Social media platform is a great way to also share legal and policy literacy and awareness raising. Would you have any good examples of that? It's a really great question. I don't have any examples offhand, and I don't think there's any examples of that in the slide deck. Yeah, I wish I had my other team members year. They might have some examples. But you're right. Many times it's not only about testing, right? I think what is a lesson that we've learned is we first look at the audience we're trying to reach online. Many of these approaches were designed for key outcomes related to testing, number of clients reached, but it's mostly testing. And then linkage to ART or PrEP. And as part of those objectives of testing or other objectives like health objectives, at least on our team, we look to see what are the influential factors to get clients in for testing. And legal or human rights issues are often, in many countries, some of the more interesting things for clients to engage on. So even if your objective is focused on health outcomes, more, focus on health outcomes, it would be great to include in your content and your demand creation things that are interesting to your audience so that you develop a following, so people follow your page, so they look to you for this kind of information, and so that when you do roll out your campaign on HIV testing, you have a following and you have people interested. So I do think alignment with those other critically important areas is very important for even your health outcomes. Now, do we have examples of where our primary outcome is literacy, policy literacy, or human rights literacy among the target audience? I don't have that many examples of that specifically, but I do think the approaches are very, they can, the planning approaches and the outreach and marketing approaches could equally be used for those outcomes, but I don't have examples at the moment. All right. Another question. Thanks for the wonderful presentation. How we can introduce in Pakistan? Yeah, lots of taboos related to HIV and social issues. I'm really pleased to hear that a number of people are attending from Pakistan. We have some related work in Pakistan with the Global Fund project that we'll be introducing maybe shortly, related to online HIV self-testing platform for key populations. We also have a guidance that can be used by programs, which is meant for more hostile settings for key populations. So the guidance actually recommends that you don't do open marketing paid ads. It recommends that you avoid some things in your online communications for the sake of security of beneficiaries or your program. But it does recommend secure ways to reach out to people virtually, ask for referrals, build rapport and trust with the clients you're reaching online, and bring them in for services. So that's a kind of guide that might be useful for programs such as those in Pakistan to be able to review. I don't think the guidance is specifically designed for Pakistan. It's not designed for any particular program, but it is going to provide some examples of ways to be maybe more secure. And it explains, what security risks you are mitigating by taking some of these recommendations. So if you're interested in that, we'll add it to our resource list, and you can request it because it's not published yet, but you can request it and you can see some of the examples there. Great. Looks like I've addressed most of the questions. I don't see any hands raised. We do have another 30 minutes. I know it sounded like we were at the end of the session, but we have a second session. And yes, it'll take 30 minutes to complete. So this next session is virtual health service delivery. So it's the next phase. It'll be an orientation approaches for online appointment booking and client management for health services. Okay, I do see a question. Any specific tool for online evaluation? Okay, we're going to actually address that now because the next phase is going from online demand creation to service access. And so there are some examples here of how to basically monitor the outcomes of your demand creation on service access. I'll be sure to address it fully at the end of this session. I hope that's helpful. All right. I see some other questions coming in the chat. I think I'll put those for the end of this 30-minute session. So the approaches that I'll review here under virtual health service delivery include client-facing online appointment booking, virtual consultations, provider-facing appointment management, engaging clients through SMS and other messengers, virtual case management, and I want to highlight an example of a tool that can actually help you manage all these things. It's called Aura or QuickRes. So first, you can see here is the client-facing online appointment booking. What are the key functions? So in these next few slides, we're going to be discussing virtual health service delivery, tools and approaches. And what I'll mainly be presenting are what are the important considerations for programs when they either look for a solution, want to create their own solution, or buy a solution. These are some of the important factors to include. And from our perspective, we actually built this into that system called Aura or QuickRes. And so because it's available, we would like to demonstrate it to you so you can see it as an example. But it's not that any program is required to use this tool. It's just openly available if you're interested. So key functions of an online appointment booking app or tool. One, it should be easily to navigate for clients to find relevant health providers. You should have functions to be able to filter your health services by, what is the type of service they want? Is it testing or self-testing? Maybe by location, so that clients can find the provider that's nearby. And also might be important to add modality. For instance, some health services by some providers could be offered as a delivered service as opposed to a pickup at a health facility or as opposed to going into a hospital. Another service like mental health consultations, they might be offered by some providers only as a walk-in, where others might offer it as a virtual consult and a walk-in. So your online appointment booking system would be benefited if you were able to allow clients to filter to find these options so they can put in a very specific request to a provider who is offering it. The other option to include is to allow clients to request a service. Sorry, there's a spelling error. Request a service or book appointment based on provider availability. So what's important here is, some online appointment booking apps allow clients to submit a request for a health service that is sent to someone centrally, who will then manage that request and maybe send that request to a specific provider. The other option, which is a little bit more aligned with self-care, is that you ask your providers to specify when are they available for appointments, right? And they put that on the system. And then clients themselves they can select their provider. They can book a specific date and time when they want to attend that service. You can see here in a picture an example of selecting an actual date and time. And that allows the client to skip a couple steps. They don't need to wait for a phone call. They don't need to wait to get connected to a provider. They directly connect into the provider through their availability. Another function is to securely collect client contact information. This would be like a phone number. This is typically required, if not very useful, for online appointment booking, so that when clients make a request or they book an appointment, that the system can send them reminders, or that the system can send them instructions on how to connect for the virtual consult, or so that the provider can contact the client during their appointment or after they miss their appointment to reschedule. So those are all important reasons to collect some kind of contact information for the client. Usually it's the phone number. And because it could be sensitive or it's personal information, doing it securely is very important. And if you have questions on this, we have some tips. The other very important function on an online appointment booking app is to have a way to track the source of the referral of the client. So an earlier question was asked, how do you track outcomes from online demand creation? And one quick answer is you can look at social media analytics, and it will say the reach, it will say the engagement, it will say the number of actions taken on the content, like maybe how many links, how many times were the link clicked, or how many times was the contact us button clicked. But it usually stops there. And so if on your online appointment booking tool, it has a function to track how the client arrived on the site. Oh, they arrived on our site to book from this ad, or from this outreach worker, or from this referral source. So Aura QuickRes has that function. It's uses unique tracked links with codes that are assigned to each marketing approach. Another way that is commonly used to track referral source is when the client books an appointment, is to have a question on the appointment booking page that says, how did you learn about us? And you give a couple options. The options should be the marketing approaches that you want to track. That's a less granular approach, but I've seen it many places, and it's an option. If you're not using an application for appointment booking, some other options to help navigate clients from online to offline for health services can be an approach called offlining. It's when the online outreach workers are working with a client that they've reached online, and then they arrange a time to meet them offline, like at the CSO or some other place. And then they use that time when they're meeting with them in person to enroll them in the normal program. Like do the enrollment form, do the testing with them, and bring them to the service site maybe. That's a pretty low effort approach, but it does require that the client meet with a staff member to be enrolled. And sometimes, clients just want to jump to the health provider. And you can also put online like a service directory. It may not be appointment booking, but at least it provides like a map or a listing of health providers, their hours of operation, a phone number to call. That is also helpful. It may not be very well tracked, like you're not able to track which clients saw that and which clients attended services because they viewed your facility directory online, but it's still helpful. It still does help clients get in for services. Next topic is virtual consults. So this is when the client meets with a provider virtually to receive a consult-based service. For instance, mental health, maybe sexual reproductive health or HIV service navigation. So you can meet with someone who can help you do a risk assessment virtually and identify your needs and navigate you to a particular provider or providers. That can be a session. Psychosocial support, enhanced adherence counseling for clients on ART, PLHIV. Those are all examples of consult-based services that can be done virtually. Here are some of the steps or considerations for virtual consults. So, use an online booking platform where providers can set their availability and they can avoid double booking. Because if a provider is engaged with one client in a virtual consult, they can't have an appointment at the same time with a second client. So having an appointment booking tool would help them arrange their calendar of consults and avoid double booking. The program with the providers and maybe the clients would identify a platform that should host these virtual consults. There's many options available. It could be as simple as a phone call, just a voice call. It could be WhatsApp, which can do video or voice. And then there are dedicated telehealth platforms which use video conferencing sort of software. From my experience, as you get into those video conferencing softwares, for a lot of our programs in Africa and Asia, it just creates a very high barrier for clients to use. They might have to download an app or learn to navigate a new system. We typically have recommended engaging on WhatsApp or on a voice call, a simple voice call. Third, automated appointment reminders sent to the provider and client with access instructions and link to get connected on the virtual consult. So that's important. When you schedule a virtual consult, you know, it's not like a in-person appointment where the client might come, you know, a few minutes late or like even 30 minutes late, and the provider's still there. If it's a virtual consult, you know, you're expected to join on time and to be there at, you know, almost the same time. So, you know, this appointment booking system can really help get clients and providers the notifications they need to say, okay, 15 minutes before the appointment, a client gets a reminder that says, your virtual consult's coming up at 3 p.m. Make sure to find a quiet and private place. And at 3 p.m., you can call your provider here, or you can click this link to start the chat. And then so those are the kind of messages that can really help facilitate a virtual consult. It would also benefit providers to have some kind of back-end interface on the online appointment booking app so they can view their consults, they can see what their schedule is for today, allow them to prepare for consults, allow them to reschedule appointments as needed. Those kind of functions and interfaces would be very helpful. Another guidance we typically have is that you know, either the provider or the client could initiate the consult. It could be either. Sometimes it's beneficial to specify who, so the client knows what to expect, who should start it. Usually the provider in a virtual consult, if they've not met this client before, or if they're starting the consult as audio only, to verify the client identity in some way. This is a standard practice in the US, is to, you know, take a look at the appointment that was booked online and confirm that the client calling or connecting is the same one by asking that, you know, for their name and date of birth or other identifier used on the appointment record, something like that. And then they provide the consultation services. And lastly, having a backend interface for the providers to report that their client attended that appointment. They could take additional notes on the services provided during that appointment if they want. And then they can also use that interface. The provider can use that interface to book the future appointment for the same client in a very streamlined way. So these are some of the considerations that we would recommend thinking about when introducing virtual consults. I'm sure there can be many more. And we'll go to the next topic. Taking a quick check on time. Okay. This is somewhat related. So this is like having a provider-facing appointment management system. So providers, you know, you can see here, this is actually a screenshot from the back end of QuickRes, the app that we have helped many programs to use. So some things that are helpful for providers to be able to see and do would be able to view, edit, and reschedule the appointments that are booked at their clinic, report appointment attendance, report if the appointment was you know, delivered virtually or as a delivered service, like home delivered, or an in-person appointment. They can document, but you know, they could potentially document on the system what health services are provided. That may not be necessary on appointment booking system. It could just be appointment and attended or not attended. You might not have to report health services delivered here. And that's because you might have another health system where you capture health information like that. It's an optional thing. It's not just optional. It's basically if your provider who is using this appointment booking tool needs the information here about health services delivered, as opposed to another system, maybe they don't have access to the other system, but if they need it here to provide support to their clients, it might be helpful to track or document here. But if it's not required to, you know, collect this information on health services delivered, it's not required to better support the client, and rather they leverage their own patient file or other health system, then there's no need to put it in an appointment booking system like this. And this kind of a backend system can also be used by providers to help assist clients to take follow-up actions. You can see here, I think you can see, let me just take a look. Yeah, it's not easy to see, but on the right-hand side, it says follow-up actions. And here there's a button that says feedback, which allows the provider to either open a feedback form that they could, hand their tablet to the client and say, here's a survey, provide feedback on my experience, submit it. When it's submitted, the provider cannot see the feedback themselves on this interface, but a higher level manager could, or the provider could press a button that would send the survey to the client's phone as a link and SMS, so they can fill the survey when they leave the facility. So that was an example of another person's question here about or interest related to client feedback and satisfaction, and maybe monitoring stigma or discrimination in health facilities that can be done there. Next topic, engaging clients through SMS and other messengers. So first, I just want to highlight like what kind of messages could be leveraged by an HIV program to better engage them in health services. So here's 9 different kinds of messages. One, appointment confirmation. You booked an appointment, and then you immediately get an SMS confirmation, which gives you the key details of your appointment. Super helpful. It allows you to, you don't need to screenshot your appointment that you booked. You don't need to enter your email, so it won't send, in our system, it doesn't send you an email. It just sends you, to your phone. Appointment reminders, which can be scheduled to be sent to the client like 2 days before their appointment, and then maybe 3 hours before their appointment. You can program them, to be sent at whatever interval is relevant. Client feedback survey can be sent automatically to clients who attend their appointments or attend health services. Client referral tool, for example, could be sent like several days after they attend services. And it can say something like, we're so glad you were able to access health services using our platform. If you would like to refer any friends to also access health services, you can share them this link. So it's just like a recommendation for the clients who did come in to refer others. Clients whose appointment is passed and they have not attended could be sent automatically a message that they missed their appointment and a request for them to reschedule. It could send them a link for them to book the new appointment. Or maybe the platform has an ability for the client to log in and find their past appointment and reschedule it, something like that. Another option, which I've seen on many platforms now, is an option for clients to report their HIV self-test results. So it's self-reporting of their results. And the example on QuickRes is when a client books for self-testing and then is delivered or picks up a self-test kit. At the point when the provider says that the kit was delivered or the kit was given to the client is sent an SMS with a link that says, when you're ready, you can go ahead and self-report your HIV self-test result here and access additional services. So they can click the link. The link includes the tracking code of their appointment. So when they get on the website, it's going to automatically put the result they reported on their appointment file. So it's going to link it. And based on their results, the system will recommend, follow-up services that they can that they can book as well, or that they can call for support as well. For instance, if this one of these last options here, if you are collecting blood samples from clients and sending them to a lab for processing or diagnostic services like viral load testing, or maybe 4th generation HIV testing, which has to go to a lab, you can have a function that basically says when the lab reports the result on the system, a message can go to the client that says your lab results are ready. Call the clinic phone number here to learn about your results, or come to the clinic. You can give specific instructions. That's something that we've explored as well. Another one is if you're using systems like Aura or QuickRes or others that are tracking clients longitudinally over time, for instance, for ART case management or PrEP case management, those systems can usually track when individual clients are likely to run out of stock of ART. And within our system, your program could use it to track when a client gets a refill, and it tracks how many days of ART were given during that refill. And then it also can check if that same client has an upcoming appointment for an ART refill. So then the programmed automatic message is if a client has less than 10 days remaining on their ART and they do not have a future ART appointment for refill, then the system will send a message that says, looks like you might be low on your medication. Would you like to book a refill? Click here. And so that's another option. And then these are all the ones I mentioned before are all individualized messages that go to specific clients because of some known information about them. Like the system knows about an appointment. They know that they access a service. They know about their ART stock. They know that they ordered a self-test kit. It's not going to a general population. It's very specific. So that's all those messages. The last one could be group messages. It could be general information about the health program, educational content, information about service availability. Those messages could be sent to groups of individuals. So it's a little bit different type. So under methods, so you can have like an automated SMS system. What that means is that the message, you predefine the message and you predefine what criteria should be met for the message to be sent. And then you need a system that is collecting information that would know when that criteria is met. An example would be like an online appointment booking application. So you have all that, and you basically code it into your system, your online appointment booking application, your case management application. And then you need to connect your application to an SMS vendor that has an API. The API essentially would allow your system to communicate to the SMS vendor every time a message should be sent and who it should send to. And the vendor goes ahead and sends the messages to the numbers that you specified. So that's one very powerful method to messaging clients. The other method is for all those messages, 1 through 8, you can do it manually. It basically means that you need staff, health facility staff, or outreach workers or other staff to have access to client information to know when to send them these messages. For instance, they can get a line list of clients who are lost to follow-up, who they should message, or they should get a line list of clients who have an appointment tomorrow, and they go ahead and message each one. So it essentially can be done manually, or it can be automated. And of course, manually takes a lot more time, but the manually could be done in a much more client-centered way. Like, manually could be clients, it could be easier to communicate with the client on WhatsApp. They can send a voice message. They can send it in multiple modalities. And the client also can respond to a manual message sent by an outreach staff and ask questions. Whereas the SMS vendor, it might be simply a one-way communication from the vendor to the client about their appointment or about their follow-up. That's why if you use the automated method with an API to an SMS vendor, it's always good to include a contact number in the messages, because typically the messages are being sent by a vendor and the client can't contact that SMS vendor. So it's better to have like some way of contacting someone for help in those messages. The other is a broadcast message. So this is when you can get an SMS vendor that is simply, has an interface where you can type in a SMS message, you can upload a list of contacts, and then you can tell the vendor to send that message to all of the contacts. It's less, it's easier to do, and there's a lot of vendors that can do this. This is useful when you want to advertise to all the clients that you have in your program a new service availability, maybe change in hours of operation. Maybe you want to deliver a routine educational campaign on a certain health service or health area, or like we said earlier, like legal literacy. Those are options. The channel that you use, SMS has been very widely used, but to be honest, I don't think I've opened up my SMS in years. WhatsApp is a lot better for engaging clients, but it's a little bit more challenging to manage like automated messages on WhatsApp. It's a new domain for a lot of people, but it's just some things to consider. There's definitely a lot of guidance related to how you should message. Some very high level things from that we've learned. One, clients should always opt in and consent to receiving messages. So if you have clients that enroll in your program, provide a phone number, and then they get added to this messaging group, you should have had in your enrollment agreement to be enrolled in messaging, or you can have an opt-out on that consent so that they don't need to be added. Things like that would be important. Allow clients to opt out of messages at any time. And for us, we always exclude sensitive health information in the message. So as you saw earlier, the low ART or prep stock, the message isn't like, are you running low on ART? The message is, you might be running low on your medication. Would you like to book a refill? So it tries to get the point across without being specific about someone's key population or HIV status or other sensitive information. All right, we are almost done, and I have not finished. So I'll just breeze over this very quickly. Virtual case management. Here's some information about virtual case management. Can be used for PLHIV to reach viral suppression. It can be used to help clients remain negative for those taking PrEP. Can be used for many other health goals as well. Case managers can be benefited by having an online appointment booking application. They can have virtual consults with their clients. SMS reminders that are sent to clients to remind them about their appointments also help with retaining clients in care. We have some links to a webinar on virtual case management and a short video demonstrating how case management can be done on QuickRes, which you can access. The Aura application, I don't have time. I do want to address any questions you have before I close, but Aura is the online reservation and case management app. It's a web app accessible on a web browser. Interfaces for clients, providers, case managers, and program managers, adaptable to a wide range of health areas, lots of data security and confidentiality functions, which I can share, and can be deployed as a country-specific platform, or countries or programs can join an existing multi-country Aura deployment that is called QuickRes. These are the countries that are using QuickRes in blue. Those that are using their own country-specific Aura in red. These are all the functions available on the system to help manage clients in care, bring them in for services. There's a lot of functions here. I won't review them, but this is just a reference for you when you get the slides. Client-facing appointment booking. Lots of considerations if you want to use a system like Aura or Aura itself. I won't review these in detail now, but they are here and for your availability to review. And I do want to take a moment. I don't know if Kaori is still on the line. If you would like to give any closing remarks, I'm going to look at some of the questions, see if I can resolve those. I am available, so I will be going through the questions and try to resolve those. And you can feel free to stay on to get your responses if you're available.
Hi, I'm not sure if my video is showing, but just to say thank you so much for Ben for this excellent presentation. We are doing this presentation in the other regions as well. So hopefully we have a good pool of TSM consultants. And as I said, our partners also have been invited to this, such as Expertise France and GIZ, who also provide TA. But all together, since we're all into this together to support countries, we hope that this was useful. And as Ben said, there can be follow-up individually with consultants as TA requests may come up from countries. We hope they will come. These are extremely important areas, up and coming areas. It's a innovative area that UNAIDS is considering very important. And it's most of all very important for the GC7 grants, which I know many of you are already involved in on the implementation. So because we're running out of time, just Ben, over to you if there's any questions to respond to. But just thank you so much. And we'll continue with the webinars for the other regions as well.
Yeah, it's back to back. Be doing the next webinar in the next few hours. But no, this was a pleasure. I am available. So I'm just going to continue and go through the questions. You all can feel free to stay on to hear some of the responses. If you need to leave, you can leave. Just so you know, we will be sending the slides to everyone. By the end of the week, we will also send a separate Word document that has all of the published resources and all the unpublished resources that you can request from us. So you can have it all in one place. If you are asked to provide support through the TSM to the Global Fund project, or you want to learn more, you can access that Word document and you can say, okay, I'd like to see these 3 documents. Let me email Ben, me, or our team, and we'll send it to you. Or if you need to schedule a call with us to get you prepared for a TA visit, you can also do that. All right, so let me get started. Feel free to stay on if you're available. I'll try to address some of these questions. Specific tools for online evaluation. So I think this is for evaluating online marketing. Again, things like the online reservation application or QuickRes are really great. You create unique links that are for each of your marketing approaches, and you use those links and you embed them in each of your ads. And then the system will track how many appointments were booked from each one of those links. So you can track, okay, among my outreach workers, these are my results. Among my online ads, these are my results. Among my organic promotions, these are my results, and et cetera. And so that is a really great way. And then you can boost that monitoring with some other things like client feedback of the demand creation, monitoring comments and narrative from social media, looking at social media analytics as well. How do you track clients who are referred to the public health care system? Yeah, this is really great. So in many of the examples where we work on HIV, the public health system, like the actual government staff, are unlikely to use the appointment booking app that we have. They're overworked. They've got other systems. They actually most of the time don't offer like scheduled appointments. It's all sort of walk-in. So the way that we've typically managed it is, even if we say clients can book online at a specific date and time at a public health facility, we have a note that says this time is for your own knowledge of when you want to go, and you will be attended along with other clients who arrive at the same time. So it's not like a provider is waiting for you to come. And at many times, these providers are not using this platform to report when a client attended. Other times, in some places, they are. So actually the health facility staff, the reception staff, they are there with QuickRes on a tablet at the reception, and the client says, oh, I booked my appointment. They say, okay, great. They report it as attended, and then they go into the clinical flow and see the clinician. Other times, the application of QuickRes is not used by the clinical team. It's used by a case manager. So this is a client's case manager. And that case manager is aware of when the client attends services, or is aware, maybe because they're in the facility, that the client came in. And in any way, they can be able to see the client or know that they came in, or validate that they came in for services. Another innovative way is, on the date of their appointment, you could send a message to the client like, did you attend your appointment? Yes or no. So this would be like an entirely client self-report if they attended. It's not the same thing as if a clinician said that they came in, but it's an option. I've not done that in programs I've supported, but it's an option. Another option is clients book online, and then at the reception desk, there's a cute little board or like a poster that says, check in for your appointment from QuickRes, or check in for your appointment from this application. They click the QR code. and maybe put in their phone number, and then it finds their appointment, and then they say, I attended. Again, it's client self-report, and like, what's the value of clients to do that? I'm not sure. But those are just some options to be able to track a little bit better. How many countries in Asia are using digital ART monitoring? I have no idea. That's a very good question. I think maybe some other people on this call might have some good examples. If you have examples of digital ART monitoring that you know about in your country in Asia, if you're like representing a program in Asia, you can go ahead and provide some in the chat. I'm sure there are a lot of this. What I've seen mostly is that like the clinical team has individual client data. It can track when clients are lost to follow up, etc. And usually that information gets like pushed in aggregate, like line lists of clients who are lost to follow up to teams to do the tracking and tracing. So that's like well, how to explain that kind of approach? If that approach is used, it's not very proactive because you could have prevented people from being lost to follow-up. So, sometimes allowing the case managers who receive those lists to actually view the individual client data to make decisions around scheduling the next appointment or reminding clients to come in using something like QuickRes could be a value add. Can you speak about confidentiality issues around SMS services? Yes. Some confidentiality issues. One, clients should opt in. They should know what kind of messages they might receive. They should be assured that the message's content is not going to share sensitive information. The biggest concern there is that the messages that are sent to their phone could be viewed by a family member or by someone else, and that could put them at risk. So that's why it's really important that clients opt in, that they know what they're opting into, and that programs adhere to their promises related to what kind of messages and content that they will send. Yeah, I'll give you an example. In South Africa, we have a system where clients are booked appointments for the ART refill. And we told clients that if you book, you're going to get messages, or you can get messages that will remind you about your appointment. But we're not going to say that your appointment is for ART. We're not going to say that you're HIV positive. It's just general. To say your appointment is at this date at this clinic. And the message content has certain variables that are modified per client, like the clinic name, like the date of their appointment, like the time of their appointment, and like who to call for help. So each of those variables are specified differently per client, and the system just pulls in like, okay, this client at this facility at this date and time. And we realized later that some of the health facilities had the word ART in it or HIV in it, in the name of the health facility. So before we actually rolled out, we were able to see that, like, oh yeah, we need to remove ART or HIV from the name of the health facility, as long as a client, can still understand where to go, like the Memorial Health Clinic as opposed to Memorial ART Clinic. Those were some interesting considerations. Is Aura an open source software? Great question. So open source software means that the code is openly accessible. And usually it means developers around the world can all contribute to the source code and make improvements. So QuickRes and Aura were developed by FHI 360 based on particular program needs, but it kept expanding. And so currently, we still manage the platform. We manage all the improvements and upgrades, and we manage the input from around the world on the new functions that they want. The platform itself doesn't have any fees associated with its use. If you want to deploy an Aura platform in your country or in a new country, it does require costs, but they're not because of the software, they're because of the hosting. So, getting a server space, getting a domain, like a website rental, and some other things. The other consideration is time and expertise. So typically programs rolling out QuickRes or Aura would contract FHI to at least, give them the training, the full training, give them the guidance on how to use the application. Essentially, while we want it to be open source, we haven't received the funding to make it open source, meaning that we don't have the funding to manage this community of practice and all these developers and manage the inputs from developers around the world to feed into Aura to improve it. And we haven't received any specific funding to make the documentation of the current site easily understood and accessible by other developers. So we're doing all that we can to make it as accessible as possible with the funding we have. If you're interested to use it, we are happy to have a call with you or local government or other stakeholders on what the system is and see if it'll meet your needs. And there are some very cheap ways to use the system, and some other ways you might request technical assistance on how to use it from us or from others. So I hope that answers your question. It's not exactly open source. It's not, it as well is not like a pay subscription service either. We don't make a profit on it through like subscription fees. All right. Well, it looks like I got through all the questions. Thank you all for sharing some of your insights in the chat. I know that it's quite late in the day for some of you. Thank you for your time. I will send the slides out, and then later you'll get that Word document with resources linked and contact information. Thank you for your time, and enjoy the rest of your day. And I'll put in the chat the email you can send for our team. It's going online at fhi360.org. All right. Thank you. Have a good day. Bye.